scatter plots, and for WNR channel there will be 3 default scatter plots. So the interesting to see, these are the 6 scatter plots, but by default the Sysmex system in their dashboard, they will show you the basic 2 scatter plots. These 2 scatter plots are basically the side scatter versus SFL, SSC versus SFL for the WDF channel. That is the primary scatter plot that many of us actually used to see. And there are WNR channel scatter plot, that is side fluorescence versus forward scatter. That is in the default view. But there are also 4 more scatter plots that we must see. So these can be customized from their settings, and we'll see why this is important. Now, if we consider malaria, so where will the parasitized RBC come in the WDF plot? So in WDF plot, it is the primary plot which most of us see, and many of us actually know it also. It falls between the eosinophil and the neutrophil cluster. So this is the blue is the neutrophil cluster, and red are the eosinophil area, and the malaria parasites, the parasitized RBCs, which are basically behaving like a WBC in the analyzer, and it will come here between those two. And so there can be many patterns which are like double and multiple abnormal irregular shapes in the neutrophil area. There can be merging of the neutrophil and eosinophil area. It can show graying out. It can show a leftward sheet of the eosinophilia. So basically, the WDF, if the parasite load is more, the WDF channel can give a fair idea if it is containing malaria or not. The problem comes when the parasite load is low. So if the parasite load is low, then it is very difficult to diagnose it from the WDF scatter plots. So WDF scatter plot in that time may just fall directly on the eosinophil zone or neutrophil zone. It can be just indistinguishable from neutrophil and eosinophils in the WDF term. So it is not the best place to see the parasite or malaria, parasitized RBC or the malaria. So the best plot to see this is the WNR plot. That is also not the default WNR channel. The default WNR scatter plots that is basically shown in all Sysmex section. We have to customize it, and we have to always focus on these two, WNR side scatter versus forward scatter, and WNR SFL versus SSC. This is a normal person's scatter plot, and we can see how drastic there is a change in the malaria infected. So we can see there are very distinct cluster that can be seen in a malaria infected person. So if we just compare with the normal person, so these are the normal person's WNR channel scatter plots, and here we can see clearly some cells. These are the parasitized RBC, which has a low forward scatter because it shrinks and it's very small. And in the side scatter, we can see it has a high side scatter due to obviously there is internal complexity in the schizone forms and also the ring forms here. And we have a moderate level of SFL or fluorescence. This is because there are some nucleic acid components inside those RBCs due to the Plasmodium species. So I'll always recommend to turn on these custom scatter plots in your Sysmex system, in your homepage, and you can detect malaria very easily. And we have done a study in AIMS. We have done it on more than 1,000 patients, and there were 46 malaria, and every one of them actually showed some patterns of cluster in the scatter plots, and the most distinctive scatter plots were in these channels, on these scatter plots. So you can basically export the data from the XN as a FCS file, that is a flow cytometry standard file that we can analyze in any flow cytometry analyzing software, and you can actually gate those areas manually, and actually you can even make out the exact parasite load of that sample. So these are the applications we can actually do with Sysmex XN, your basic Sysmex XN. So the advantage is you can diagnose even in unsuspected cases. You can detect in extremely low parasite count, even less than 10 parasite per molecular, even when it is very difficult to diagnose it in a peripheral blood smear. You can actually get some idea from Sysmex XN. You can detect malaria from WNR plot in other hematological malignancy cases or something where we even don't suspect malaria in the first place. So you can just do it from the WNR channel. Because WNR channel, there is not much even change. and making estimation of the parasite load from the density of the malaria cluster. That is very interesting. If you can just visualize the cluster and the density of the cluster and compare with WBC cluster, and you can actually estimate even before seeing the peripheral blood smear. So I'll just summarize it with a take-home message. So always screen the scattergrams. I think most of us actually screen the scattergrams, and we all should do. And it will hardly take 1 or 2 seconds, and customize the Sysmex section dashboard with the light background. So by default, the dark background is often turned on. Often it is very difficult to see. So we turn on the light background, always see the malaria cluster, and there are many other flags also, Delta, WBC, IRBC, that I will not go in depth today. So we are basically focusing on the scattergram, and always search for the malaria parasite and make estimation of the parasite load. That is a very interesting thing that we all should all do. So thank you very much.
Thank you so much.
Thank you, Dr. Sarkar. This was really illuminating. And because of the delay in starting, we shall postpone the question answer session for tea break. And we have the proud honor of, yes, Dr. Sarkar, please. I'll go later. All right. So we have the proud privilege of having amongst us Dr. Biman Saikia. I don't think he needs any introduction, and it's anyway on the screen. It's really a great pleasure for us to have you with us, sir.
Very good morning to you, and it's a pleasure to be here in Kolkata amongst all the practicing pathologists of Kolkata. And I'll admit that I'm a little bit out of practice these days, so I'm not a practicing pathologist that way. My job today will be to this is more of an introductory talk to the topic of autoimmunity and vasculitis. So it will be more of a theoretical talk and might get a bit boring at places, but I'll try and wrap it up quickly. And actually I was very pleased to see the scientific program, because many of the topics are so much in detail that they will be discussed in the later topics, so I don't have to go or delve into them in detail. So before understanding autoimmunity, we have to understand what is tolerance. So tolerance is basically the capacity of our immune system to distinguish between self and non-self. And there are various mechanisms of tolerance, various layers of protection which prevents our immune system reacting against our own host cell components. So it's a state of unresponsiveness to self-antigens. And there are the central mechanisms of central and peripheral tolerance that we all know. Just a minute, Okay. So there are the central and the peripheral tolerance mechanisms. So we are very familiar with those. So I won't go into detail into that, but just to be brief, in the thymus, whenever there is a cell or a T cell which is strongly reactive to a self-antigen, it's promptly deleted. So the central tolerance is basically the deletion of all the lymphocytes which are specific for self-antigens. And majority of the thymocytes, more than 90% of the thymocytes, will be deleted in this process of central tolerance, and only a few lymphocytes will actually, which are not reacting to the self-antigens and are basically basically cells which will recognize the non-self antigens will come to the periphery. But despite these filtering mechanisms of central tolerance, some T cells which are autoreactive will come to the periphery. And this is handled in the periphery, and that is called the peripheral tolerance. So whenever there's a T cell which reacts to the self-antigen, it undergoes apoptosis or energy or a state of unresponsiveness. So there are these various layers of protection that is there. And in the central tolerance, I must talk about the the role of the medullary thymic epithelial cells and the protein called AIRE, or the autoimmune regulator. Now, this molecule is very crucial because this is the protein which will allow expression of all the self molecules on the thymic epithelial cells, so that all the T lymphocytes are taught. So this is the teaching that occurs within the thymus, the school in the thymus. All the T lymphocytes are taught about the self antigens, and any T lymphocyte which is highly reactive to a self antigen will be deleted. They will undergo apoptosis, and this is the majority. This will happen to the majority of the T cells in the thymus, and only those cells which are intermediate to low reacting to the self antigens will be positively selected. So this is the process of positive selection and negative selection. And some of these cells, this is basically to filter out all the cells which are self-reactive. But despite this filtering, again, as I already told you, some T cells will come to the periphery, which are autoreactive, and we have mechanisms of peripheral tolerance like the ignorance, modulated expression of CD5, the expression of the inhibitory molecules like CTLA4 or PD1, and extrinsic mechanisms like the regulatory T cells and the B cells and tolerogenic dendritic cells, which will handle tolerance at the periphery. Similarly, in the B cell also, that is the majority of T cells, and even in the B cells, we have the mechanisms of creating tolerance like receptor editing. So whenever there's a B cell with a receptor or a B cell receptor which is reactive to a self antigen, it will undergo further VDJ recombination and hypermutation, which will change the nature of binding of that antibody to antigen, and it will no longer then bind to the self antigen. So there are this, and they similar to the T regulatory cells, there are B regulatory cells which will suppress the cells which are self-reactive. So despite this protective system of regulation, self-reactive clones of T cells or B cells are occasionally they're activated, and so autoimmunity basically refers to the presence of these self-reacting T lymphocytes and T lymphocytes and antibodies, or B cells and their antibodies. So autoimmunity is basically just the mere presence of these self-reactive T cells and B cells. It doesn't mean that the patient has. Many normal individuals will have autoreactive T cells and B cells, but that doesn't mean that the patient has autoimmune disease. So autoimmunity basically it refers to presence of these autoreactive T cells and B cells, and it can be present even in normal individuals. Now then, what is the difference between autoimmunity and autoimmune disease? The marker of autoimmune disease is tissue damage. So whenever, because of these autoreactive T cells and B cells, there is tissue damage, that is when we have autoimmune disease. Okay? So autoimmune diseases, as we know, they are diverse group of conditions, and they characterized by a disturbance that causes an aberrant B cell and T cell reactivity to normal constituents of the host. Now for the clinician, because of the myriad manifestations these patients can have, the challenge for the clinician is to, in this myriad of clinical presentations, to arrive at a diagnosis. And for the laboratory, the challenge is to prove that this autoreactivity is the cause for the manifestations. So whenever we demonstrate autoreactivity in the laboratory, whether in the form of antibodies or autoreactive T cells, now our challenge is to prove whether that autoreactivity is causing the disease or not. Now, there are certain, similar to the Cox postulates, there are some, what's called the Witzbeek postulates, where the autoimmune diseases, basically, they have to be characterized by the presence of the B cells and the T cells, which are autoreactive. And if we transfer these B cells or T cells, passive transfer, then it will, into experimental animals, it will have to cause the disease. There has to be a transplacental passage of disease. So these are certain postulates, but autoimmune disease may not fulfill all these criteria, and not always. So the transplacental passage of the disease is one very important manifestation of autoimmunity, and I'd like to highlight an example here. The congenital heart block and neonatal lupus that is associated with the anti-Rho and the anti-La, or the SSA and the SSB antibodies. Now, this is a very important clinical situation where we have to be aware of. Now, we know that the SSA and the SSB are associated with Sjogren's syndrome, right? But if a lady who is pregnant has anti-Rho and anti-La antibody, now these antibodies, they cross the placenta, okay, and cause congenital heart block in the neonate. Because the antibodies, these antibodies, they cross-react. There's a mimicry, antigenic mimicry with the conduction system of the heart. So these antibodies will cross the placenta, go to the fetus, and cause congenital heart block. Now, sometimes what happens is the mother is not even aware that she has these antibodies. And it's for the first time that you come to know that she has SSA and SSB because the child or the neonate had congenital heart block. Okay, so this is very important for us to realize. So whenever you encounter SSA and SSB in a young female and she's pregnant, you have to be very cautious. And you have to know this, that the SSA, SSB antibodies can cause congenital heart block. This is because of a passive transfer to the placenta, and can also cause neonatal lupus, which is characterized by cutaneous and cardiac manifestations. Okay? So that is about transplacental transfer of antibodies. Now, when it comes to the clinical and laboratory findings, we know that only some of the individuals who have these autoreactive T or B cells will have the disease. And autoimmune disease has no simple or uniform set of signs and symptoms. You know, as I said, they can have a myriad of symptoms, and the symptoms are basically because of inflammation. Now, that inflammation is similar whether it is caused by autoimmunity or caused by an infection, because the manifestation is because of the inflammation that is the end result of either infection or autoimmunity. So, for example, if you take the glomerulonephritis, the morphology of the inflammation that we see, or the morphologic manifestations that you see in a biopsy, they would be similar to what is caused by infection. So it's basically the inflammation that happens, and so that's why you require adjunctive laboratory testing. And the easiest method of detecting autoimmunity is demonstration of autoantibodies, because that is easy. For B-cell autoimmunity, we have the autoantibodies that can be demonstrated very easily and that is the tool right now we have, because to demonstrate T-cell autoreactivity is very difficult. You know, T-cell autoreactivity requires a lot of sophisticated technology to demonstrate autoreactive T-cells. So demonstration of autoantibodies is what we laboratory personnel now rely on to diagnose autoimmunity. Now, it's not only the antibodies. Now, here I like to bring in the story of celiac disease. This is a disease which has been very well worked out, because here we have the gluten, which is the environmental factor. So we have the inciting factor, which is inciting environmental factor, which is the dietary gluten peptides, and which is when ingested, you know, it is the TG2 enzyme, transglutaminase, is deamidates these peptides. Thank you. It will deamidate this peptide, and they will be recognized by the antigen-presenting cells. And if the individual has this HLA phenotype, HLA DQ2, DQ8, these peptides will be presented to the CD4 cells, okay, which will be activated. They will produce a lot of interferon gamma production and TNF alpha, and that will lead to mucosal destruction. Okay? And these CD4 cells, which are basically primed by the dietary gluten, They will also induce the antigen presenting to cells to produce a lot of IL-15, which will again cause epithelial damage. So here you see that the bulk of the damage here is caused by the T cells. But we diagnose celiac disease by demonstrating antibodies. Okay? Now, antibodies may play a pathogenic role in celiac disease as well, but they are more of a disease marker. Now, how do these antibodies develop? Now, the inciting factor here is the dietary gluten. So these CD4 cells will help the B cells to produce antibodies against gluten. Okay? So there are antibodies against gluten, but there are also antibodies against the TG2 or the transglutaminase. Now, why does it happen? That's because the TG2 make this, when they deamidate these peptides, gluten peptides, these gluten peptides are very sticky peptides. They bind to the TG2, and it forms a TG2 gluten peptide complex. And because of, epitope spreading, the antibodies which were initially directed to gluten now will also be directed gradually to the TG2. So that's why we have transglutaminase antibodies against the TG2. So that's how the whole thing works. Now, as pathologists, we will be, and you already had a workshop on immunofluorescence, and I'm sure you must have seen these kind of photographs. We see this is the ANA in Hep2 cells, and we are familiar with this is a diffuse pattern. Okay, this is the DFS, this is the centromeric pattern, the speckled pattern here, you see the oligonuclear dots or multinuclear dots pattern, the nucleolar pattern, the rim pattern, the ribosomal pattern, and this is the AMA or the anti-mitochondrial antibody pattern. So these are patterns that rely on in the laboratory to diagnose autoimmunity. Now, I'm sure this will be dealt with in detail in later talks. So this is a DFS pattern that we have to, when we are doing interpreting ANA, we have to differentiate this pattern, the DFS, because this pattern is not associated with systemic autoimmune diseases. So this is more of a pattern that is seen in normal individuals. That's why you have to be very careful in differentiating this pattern from a homogeneous pattern or the speckled centromeric pattern or whatever. We'll be familiar with this. Nowadays we report ANA as the AC patterns or the anti-cell, because this term has been adopted because the antibodies are not only against the nucleus, it's always also against the cytoplasmic components. So nowadays they call it AC patterns or AC1 and AC2, and these are different patterns. You have to familiar with, I'm sure you're familiar with this reporting pattern. So whenever you report ANA, your report has to include the substrate that you have used, which will be Hep2, the kind of positivity, whether it's nuclear or cytoplasmic, then what is the pattern, and what is the intensity. So these are and the dilution that you have used. So these are the factors that your report has to incorporate when you are reporting ANA pattern. So this is the ANCA, this is the P-ANCA pattern. You must be familiar with the C-ANCA pattern. Okay, these are typical patterns that you have to be familiar with. The C-ANCA, you should call it the C-ANCA pattern only when you see the interlobular accentuation. So without this intensity that you see in between the lobules, which is called interlobular accentuation, you should not call it a C-ANCA. Okay? So this is a typical C-ANCA pattern. You have to see this interlobular accentuation to call it C-ANCA. Similarly, for the P-ANCA, these intranuclear extensions or the blebs, they call the blebs. This is very characteristic, and only when you see this, you call it P-ANCA. Otherwise, you call it atypical P-ANCA or atypical C-ANCA. So these are composite testing to demonstrate antimitochondrial or the PCA or the SMA or the LKM antibodies. So these are the various tests, antibody demonstrations that you can do. This is a neurology panel, and I won't go into details of this. These are for the bullous diseases. Now, okay, my time is already up. So it's okay, okay. Now this field is actually a very continuously evolving science. So if I may exemplify, if you take membranous nephropathy, now the autoantibodies to the PLA2R, that was described only recently in 2009. So we're still evolving, and more antibodies or I'm sorry, the antigens are being discovered, and we still are continuing to learn, and this is very evolving. And for some conditions, like the identification of target antigen is just beginning. Okay. So, for example, the autoantibodies to nephrin in a subset of patients with minimal change disease. So these are very recent developments that we have seen. So autoantibodies as markers of AID, there's no doubt in that. So, but the serological findings can be quite diverse because there is no direct association between an autoantibody and a disease phenotype. Okay. So, for example, in systemic sclerosis, anti-SCL70 is associated with diffuse skin involvement, whereas if there are antibodies against the centromere protein, it becomes a limited disease. So why different patterns of cutaneous fibrosis in the same spectrum and different antibodies, we don't know. So a lot of things that we still don't understand. And for example, in myasthenia gravis, there are antibodies to anti-acetylcholine esterase. Okay, that's we had known for a long time. But when people encountered some typical myasthenia gravis patients who are negative for acetylcholine esterase antibodies, then they looked for other antibodies. And now they have found the anti-MuSK antibodies. So there will be a subset of myasthenia gravis patients which are negative for acetylcholine esterase, but they are positive for MuSK antibodies. So the utility of serology is not only in diagnosis, but also in the assessment of disease activity and the treatment response. So there are some concerted efforts at looking at finding antibodies, and people have found autoantibodies even in chronic pain and in psychosis. So even psychosis tomorrow may turn out to be an autoimmune disease. We don't know because we are still learning. And some antibodies, like for example the anti-GAD64, it can occur in different diseases. So anti-GAD antibodies are seen in stiff person syndrome as well as diabetes mellitus. So there are, why two different diseases with the same antibody? We don't understand. Okay. So the same phenotype can be associated with plethora of autoantibodies, and the best example is lupus erythematosus, because in lupus you see so many antibodies, and yet the disease phenotype is same. So we don't understand a lot of things and how it happens.
Dr. Saikia, have you fit?
Yeah.
We'll have to wind up.
Yeah, I have to,
Yeah,
because
please.
I have a lot more slides.
Yes.
Genetics, it can be, I won't go into details. So there are a lot of genetic factors like the MHC and the PTPN22 and a lot of things. And there are the single gen defects of autoimmunity, where like the AIRE and the CTLA4 genes. These are single gene defects which will give rise to autoantibodies. But these are diseases where you don't see ANAs or the typical autoantibodies. These are diseases because of single gene defects. For example, the AIRA defect will give rise to APS1, but you don't see autoantibodies here. This is all T-cell mediated kind of disease. And similarly, in diseases like IPEX, where there's a mutation in the FOXP3 gene and there are no T regulatory cells, the phenotype is very different because you don't see autoantibodies there. Triggers of autoimmunity can be microbes, factors like smoking, a lot of drugs and chemicals. Dietary fibers, I've already given you the example of gluten hypersensitivity. Drugs and chemicals, a lot of drugs can cause lupus-like syndromes. So this is drugs and chemicals can also give rise to malignancy. With now a lot of malignancies, for example, ovarian tumor, patients with ovarian tumor, they develop these NMDA antibodies, okay? So a lot of malignancies, and with the use of checkpoint inhibitors that is in practice now in therapeutics, a lot of autoimmune manifestations after treatment with checkpoint inhibitors are also there. And there's this concept of preclinical autoimmunity where the patients are positive for autoantibodies but they don't have the disease. So this is called what is called incomplete disease. So this could be a disease in evolution where, so to differentiate between the preclinical autoimmunity and disease is one area where we pathologists and clinicians find it very difficult to decide whether if the patient is positive for an autoantibody, whether to consider that the patient should be treated or not. So this concept of preclinical autoimmunity is also there. And this is very important because we have an opportunity to treat the patients even before the disease is manifests. So there's a window of opportunity, but we need availability of a functional assay. I'll take an example here. Diabetes, for example. If the patient is positive for autoantibodies, anti-insulin or GAT65 or autoantibodies, and the patient has a impaired glucose tolerance. Now we have a functional assay here. We have an antibody, we have a functional assay where you can see the glucose tolerance. If the glucose tolerance is impaired and there's an antibody, we can think of treating in these patients. So there is an antibody, teplizumab, which has actually been FDA approved for treating patients who are autoantibody positive and has a impaired glucose tolerance. Similarly, if the anti-CCP patients who are anti-CCP positive and they have pain, even though the typical RF is not there, the clinical manifestations, but you can still think of treating these patients in preclinical autoimmunity. So it all depends on what tests we are available to predict the disease. So I'm sorry, the talk was lengthy, but thank you so much. I had to skip a lot of slides.
Thank you very much, Dr. Saikia, for that fascinating lecture. And we would have loved to listen to you for longer, but then the constraints of a conference. We have time for just about one question. Anybody? Okay. So
Anyway,
can
these
we
topics
just-
are going to be covered in rest of the talks.
Yes,
Thank you so much. Thank you.
Any questions? You can please interact with Dr. Saikia during the breaks. Dr. Saikia, please. We'll just-
Happily announce. Sumeet. May I call?
No, there was a change in chairperson for this first
Shravasti.
session. Dr. T.K. Ghosh hasn't come, so Dr. Shravasti Roy is chairing this session. So Dr. T.K. Ghosh will be chairing the next session. And
So-
we will again hear Dr. Saikia tomorrow in another 2
So you can see Dr. Shravasti Rai's CV on the screen. We are sorry that Dr. T.K. Ghosh couldn't make it, but we have equally erudite Dr. Shravasti Rai to replace him today. And may I call Dr. Sumeet Kumar Sharma to give a small talk. Please, other than our respected invited faculty, I would request everybody to shorten their talks a little bit,
Yes.
So, please. Okay. Good morning, everyone. I'm myself, Dr. Sumeet Kumar Sharma, would be discussing few things about laboratory diagnosis for spondyloarthropathies. Now, as we know, for establishing the clinical relevance for SPAs, it's a cohort of chronic inflammatory diseases primarily affecting the sacroiliac joints. And
the spine as well. So the patients presenting the lower back pain for more than 3 months are to be considered for detection or for identification of SPAs. Now, as per the assessment of spondyloarthritis by International Society, ASAS, it all includes the umbrella of ankylosing spondylitis, psoriatic arthritis, reactive arthritis, and there are several others undifferentiated SPAs as well. So as per the classification for criteria for ASAS, all those patients who presents lower back pain for more than 3 months and are younger in their late 30s or mid 40s. So in the classification of ASAS, there are 2 arms, the radiological arm and the clinical arm. For the radiological arm, the patient may present changes in the plain X-ray films, which would be considered as a radiological changes and to be seen as radiological axial spondyloarthritis. However, the patient is presenting the symptoms, but there are no significant changes being recorded in the X-ray films, then that is to be considered in the non-radiological axial spondyloarthritis. For identification as per the ASAS classification criteria, the patient must present any of these features along with sacroiliitis or an imaging with any of the features of lower back pain, uveitis, psoriasis, even IBDs as well, and may or may not having a clinical history or family history of SPAs. Or otherwise, if the patient is found to be HLA-B27 positive, as we will be discussing later in the presentation, that HLA-B27 holds a great correlation and very high incidence in AS. So if the patient is reported to be HLA-B27 positive, then any of those 2 clinical SPA features along with HLA-B27 positivity would be considered as a clear-cut case of SPAs. Besides the classification for axial spondyloarthritis, there is another classification given by ASAS for peripheral SPAs, which also includes your peripheral arthritis, enthesitis or dactylitis along with any of the following features as mentioned. But one thing very much prevalent and common was in both the classifications, HLA-B27 has been given a very important consideration. So why this HLA-B27 is very important? So HLA-B27 is a gene variant of HLA-B found on located on the chromosome number 6, and in totality it comprises of 6 exons. However, mutations detected in the exon 2 and 3 primarily are of clinical relevance for identification of SPAs. And why it becomes more crucial for having an not only accurate diagnosis but precise diagnosis for HLA-B27 positivity, because it is highly polymorphic gene variant and has more than 200 subtypes, alleles and their subtypes reported so far. So as HLA-B27 can run in the family, even in the second degree of cousins, it has a strong genetic predisposition. In totality, the 7 to 9% of general population may have an HLA-B27 positive gene, but those who are found to be AS positive, more than 90% of them are found to be HLA-B27 positive. And that is why in all those cases where in the early diagnosis of imaging, where it is not presentable as a significant change in the X-rays or in MRI, in those cases, HLA-B27 plays a pivotal role. And however, incidence of HLA-B27 positivity is more in case of axial spondyloarthritis as we compare it with other forms of arthritis. So in totality, the screening assay plays a crucial role in not only accurate but a precise diagnosis covering all those alleles and their subtypes. Now for detection of HLA-B27 mutations, there are several techniques available, but majority we discuss about flow cytometry and real-time PCR. So if we compare both the technologies, the HLA-B27 is a step way ahead because a very crucial aspect in this identification of mutation is that we may end up getting certain indeterminate results in flow cytometry besides all other clinical and commercial aspects. And with real-time PCR, it is for sure 100% confirmatory as prescribed by several pathologists and the rheumatologists generally recommend for the HLA-B27 testing by real-time PCR. Now, with the advent of technology and the post-pandemic era, it has become very convenient for all of us to easily direct for the HLA-B27 detection by real-time PCR. And more importantly, it is very easy and comparatively interpretable as we go for the HLA-B27 detection by real-time PCR. So there have been several studies across the globe where they have reported that detection of HLA-B27 mutation with real-time PCR found more better results and sensitivity as we compare it with flow cytometric results for screening and for confirmation of HLA-B27 positive sample. And it is found to be more sensitive and specific than flow cytometry results. And there have been several studies, and it is not only the detection, but also the allele-specific identification, which is also equally possible through real-time PCR identifications. So all these studies have concluded one thing, that real-time PCR testing for HLA-B27 mutation detection is way more sensitive and specific as we compare for the flow cytometry, because specifically it avoids the indeterminate results presentation. And because that was the major issue as found out with the flow cytometry. And as I mentioned, with the post